we might get started. Can everyone hear me? I'm Jeff Curry, and I'm going to be chairing this session. There's a few reminders I need to sort of say. So one of them is turn your phones off, or at least turn them on to vibrate. And if you need to take a call, just go out and just quietly as you can. There's the Federation app that you can download. If you haven't got it already, you're probably not going to get it, so you'll know about that. Of course, you get the little barcode thing to scan for your CPD. Remember that it's not just about collecting points. If you're a technologist, you've got to do your reflection to make it count. And then, of course, after lunch, there's the poster session. So I encourage all of you to head down to the posters. In particular, poster 229 would be worth looking at. That's mine. So go on and check it out. It's actually a world first. It's actually the first time that we've done PET CT on bees. So go and have a look at that. So I'd like to welcome, so this session's obviously about new technologies and applications in PET, and there's a bit of PET MRI as well. So our first speaker is Scott Evans. We'll have 20-minute sessions. If they finish, we'll try to include question time in that. So we might have a few minutes at the end if we don't. So I'll give you a bit of a heads up when you've got a minute to go, and then we'll just yank you off the stage. So our first presentation is Innovation in PET CT, New, Now and Next, and Scott Evans. So thank you for your time.
Great. Thank you, Jeff. Now, PET CT has actually come quite a long way in the last recent years. So in the last few years, we sort of gained time of flight, which basically gives us much better resolution and sensitivity. And basically, you can see in the bottom slides there where it actually turns back projection into quite an actual improved picture. These sort of advances have also got actual corrections for actual response across the field of view. And all these things turn into actual resolution recovery and improved sensitivities. And bottom line is the pictures we get out of them. So the picture on the left, that's basically an iterative reconstruction that basically it's a actual resolution of 2006 images. So scanners are basically the crystals of those times and the processing. I've run through the processing that I've got available on my system at Westmead, and you can see on the very far right, what you've got is the resolution recovery applied, the actual time of flight, the sensitivity corrections, and basically you can see the changes that have gone through the years of the actual imaging. So you can now sort of see much smaller actual lesions. They may not actually change the direct outcome for the patient, but you're actually seeing much smaller objects. That's all been possible because with the iterative reconstruction, you're able to feed in all kinds of corrections. And the next sort of phase we're going to be seeing is this sort of thing where you have metal artifact reduction. The hip prostheses just kill PET scans, and when you actually look at the images, those artifacts just ruin the pelvis, particularly in things like PSMA. A number of times you have an old gent who's basically got PSMA, prostate cancer, and as well as hip prosthesis. It makes it very difficult to interpret the scans. Metal artifact reduction is going to actually revolutionise those imaging in that area. Now, something I've played around with a lot, those who've followed me around the years, respiratory gating. We basically use this on chest and in the liver for a lot of our patients at Westmead. So anyone who's got colorectal issues, anyone sort of gallium octatides, neuroendocrine tumours, we basically hit them with basically a gating respiratory, either a freeze frame or an actual Cine acquisition, basically on just about all cases. What you see here is the actual imaging, the end result, basically there, but we actually have like a sensor that basically sits on the patient's chest. The actual sensor exerts a pressure and basically you get a signal from them, and reconstructs the sequence of images from the list mode into a sequence of 6 to 8 images that can play back in a Cine form. Now this is Phantom I did a few years ago, and basically you can see what it's actually able to do is resolve really small, the smallest sphere in that actual Phantom. That's a 20 millimetre translation, that basically the Phantom is actually, it's sitting on a little articulating arm, and it's actually moving that actual Phantom, NEMA Phantom, and you can see it actually is picking up the smallest of the actual of the actual beads, even though it's 7 millimetre size with respiratory motion. Now this is actually the reason why we do this sort of thing. On the picture on the left, you can see this is an actual lung cancer sitting right against the actual wall of the patient's lung, similar to the one across the other side. And on the whole body sweep, they look very similar scans. You've got the lesion that's right against the lung, and to actually try and work out whether that actually is plurally involved or not, you use the actual gated respiratory. You can see this one is translating quite beautifully. It's actually free of the wall. Both of these patients went to have surgery, and this one had an infiltration of the pleura to like 9 millimetres and into the actual by the time it actually got to the actual theatre, they weren't actually going into the muscle. You can probably talk yourself into involvement in that muscle there. Now, this is the freeze frame image, and what we do, we use the same sensor, and it basically allows us to actually get a motionless portion of the respiratory cycle. The sensor is basically gives you the same sort of waveform, and basically it selects the most motionless portions of the respiratory cycle. You can see on the images there, where you're going, we've got on the top slide, you've got the actual lesions that are actually mobile and basically blurred out. They're basically difficult to actually define the boundaries of it. With the HD chest, you can see how much more purely defined they are. And with our actual colorectal patients, we're actually identifying a lot of lesions we're just not seeing on the whole body sweep. Now, at the conference here yesterday, I was basically seeing GE and Siemens, and they both are actually interfacing this actual image, this sort of the freeze frame image, into a whole body image. So they actually knit the actual freeze frame image into the whole body sweep. So you have the whole body MIP. So basically your MIP, basically you see the original MIP with basically the motion involved, still included inside it, but they'll also output and replace the slices where they actually have the HD chest or the freeze frame images in there, and basically it gives you a much better image to review. I did actually manage to break the actual HD chest, so if you do have motions over about 40 millimetres, which is not typical in patients, but in a phantom you can do that, and I was able to actually break this whole setup. But if you've got movements less than about 20-30 mils, you can actually get greatly improved imaging. Now, list mode, it's not new. It's been around since way back before when Jeff was basically at RPA. And what it's found is basically a wonderful new niche in PSMA imaging. So what you can see here on the left, you've got an early time point. So what we do with our PSMAs at Westmead is we inject them on the table. We wait until the FDG run's done on that day, then we basically, PSMA is basically manufactured, and as soon as the last FDG patient is off the bed, the first PSMA goes on, and then basically we're injecting them on the table, cannula in their arm. So on the left you can see 0 to 2 minutes, and on the right you can see 0 to 6. And you can see the tumour uptake is already there, even at 0 to 2 minutes, but you've got the blood pool, but by 6 to 8 minutes that actual lesion is well defined, there's nothing else around it. And here's the whole body sweep for that patient. They come back, whole body MIP, sorry, at 1 hour after injection. Now, this is quite an easily identifiable lesion. It's well away from any other structures, but the worst case you want to see is this. This was a case that Siemens have actually taken. They've gone on the actual station downstairs. So if you want to annoy David Edwards, and actually he's got the data there, he can actually show you this and just tell him Scott sent you. But what you have is across the top there, a set of MIPs, basically from the lateral projection. This is 0 to 2. You can see there's an area of focus that's lit up straight away. 2 to 4, 4 to 6, 6 to 8, and the start of the bladder is starting to appear at 6 minutes, and it's well and truly there at 6 to 8. So the picture at the bottom, you can see there is bladder, there is lesion. The tumour actually grew around the ureter, and the patient had previous surgery. They removed the ureter, reimplanted it, and basically some of the tumour was still around the ureter itself. So over the years it regrew, and you can now see what it presented would be an absolute impossible scan to read if you only did the delays. But because we did the dynamic early, we can actually see that tumour is actually wrapped right around the ureter, And you can see the actual bladder had filled up, and by 1 hour we had no chance of picking that up. But these images basically sold a number of my doctors on dynamic imaging early, and I'm very glad for that fact, because this is actually one of the best cases I've got. Now, alternate uses of standard tracers. We've been doing a lot more sarcoid imaging at Westmead. We have an amyloid clinic at Westmead that are picking up patients with heart disease and heart issues, and as a result of that, we're having to do a diagnosis of, is it sarcoid, is it amyloid? So when it comes to the sarcoid imaging, what we've been doing is using a high-fat, low-carb diet. Now, in that the diet will come in a moment, but the winning meal in that one is Kentucky Fried Chicken. Basically, the patients love the fact that we actually tell them you can have Kentucky Fried. Basically, we give heparin with the actual injection, and just before the actual injection, and then basically we do the scan at 1 hour. You can see in this patient you've got several areas of focal uptake, and this patient had already had a cardiac biopsy and they missed it, probably because they were actually biopsying this bit over here. But with this PET scan, we were able to actually show them exactly where they actually needed to biopsy, and they actually wound up being able to go, not the heart, but actually up here, away from the actual cardiac itself. So what we're doing, we're giving a little bit of heparin. Basically, it's weight-based, and it basically turns off a mechanism in the heart to take up FDG. And it means you're able to actually look at the heart and say, okay, if I don't have uptake, that's normal. If I do have uptake, that's abnormal. It's basically weight-based, and you give it 15 minutes before. It is a bit of a dose. It's not something you want to do every day on someone, but it's basically like a diagnostic level dose that you would use if someone had PE, and basically on the first, if you phone them in your clinic. So the diet itself, it's not no carb, it's basically a low carb. So the reason we went with that is we looked at some of the actual diets from around the place, and that those high-fat diets with no carbohydrate, you just wouldn't want to eat. You couldn't get around it. So with this diet, you're able to do like a ham cheese omelette with mushrooms. That's usually a winner. In the afternoon, the patients will have like a light salad for lunch, followed by like a Kentucky Fried Chicken for dinner. Or for the kids, they tend to actually do Kentucky Fried, Kentucky Fried, Kentucky Fried. There's a couple of other. The main thing is you also have to prepare for the patient with the PET, obviously. So it's basically no sugar, and there's plenty of water, no tea or coffee. You can have tea and coffee, but no milk or sugar. And that can be a bit of a problem. But here's our negative and a positive. So the top there, you can see beautiful blood pool. So you know that you've got complete suppression of the myocardial uptake, and that's what you're looking for. And our positive scan on the bottom there. Blood pool is not suppressed in that one as well, but you can see that the uptake has actually gone into all of the sarcoid cells. So this is a slightly different use of gallium octreotide. This is a patient with meningioma. A couple of things to point out on the scan. You can see part of the skull is missing. The actual bone has been removed to actually release the pressure. These tumours were growing. She's had these tumours for like 25 years, and at some stage they've actually removed part of that bone and left a skin flap to protect it, to depressurise the head. But you can see the focal areas of all of those meningiomas, and with this patient, she basically, because she was positive with octreotide, it meant she was somatostatin positive. It meant she could actually go on treatment to actually suppress the growth of those tumours. And this is basically a scan that's been used to actually determine whether there's any use of actually giving her somatostatin. And you can see from the scan, most definitely there is. It's a lot of every single one of those lesions took up octreotide. Now, the crystal side of things, LSO has basically been around with the mainstay for the last few years, and if anyone's ever actually grabbed hold of a lump of that stuff like I did, it's bloody heavy. You hold it in your hand, and basically I was really surprised at just the weight. First time I took a photo of it, the flash was on, and you can see the wonderful light output you get with the LSO. In the background, you can see this is actually how they start with the LSO. It basically starts off getting drawn out of a kiln, and if you want to see something that Siemens didn't mean to put up, about a year ago, they put up the little Healthineers video, and basically there's, in that sequence of images they have for their Healthineers, they actually have the factory location of the actual a view from the floor of how they make this stuff. They didn't actually mean to put it in there, I think, because when I went for that tour, they basically, there was no photos anywhere, and there's big angry guys telling you to stop doing it. But they pull this out of the actual kiln, they basically slice it up like pineapple, and then basically make little rods out of it, and basically end result is this stuff. Now, those crystals are basically going to be around for a while, but basically everyone is basically going over to these silicon diodes, basically replacing their PM tubes. Last night, Siemens basically announced their version of that equipment, and basically had to rushedly put this slide in there last night. Just like, everyone's doing it now. So basically it's new technology. It basically is the machine that they're basically talking about, and the GE machine, they're all basically getting improved sensitivity 2 to 5 times greater than what there has been with the previously, and I was really quite surprised with that number last night. So new tracers, I've titled this New and Now. Being in Sydney, I don't really get to play with this stuff very much. I've had through a bit of it a couple of times, so that's it. It's very well available in Melbourne. We can get it in Sydney, but it's not a habit of choice of our clinicians in Sydney to refer for these patients. So they all come to Melbourne, and you can see the wonderful images you get with the Alzheimer's patient in the middle, healthy control, FTD. This fluorobetaben is one of, like, I think 4 traces that are available in Melbourne. Is that?
Well, four are more common.
4. And they're finding more variations and basically working on them all the time. Other traces that are just always blow my mind when I come to these conferences, tau. Basically, you can saw a wonderful session again this morning. The uses and the actual faculties of it. The reason why they're actually so important is this is a slide that basically came from S&M, and basically you can see there's the tau, there's the beta amyloid. They're basically the diseases they're actually able to detect. Now, the thing is, these are other proteins and other agents that basically result in diseases, and basically we don't have as many of those actual molecules are yet to be sort of labelled as well and become in the clinic. So that is something it's developing in time. Is the more you actually look at the international conferences where these are cells actually being targeted, and to actually develop scans for imaging. The one thing I do get a lot of in Sydney is FET. This is a patient for brain tumour. Middle images are the FDG, the top row is the FET, and the FET is just defines the tumour beautifully, and basically the FDG, it has a low metabolic response in this patient's tumour, so it is a slow-growing tumour. But you can see the FET, it delineates the actual tumour beautifully, and it basically, if I had F18 on tap, I'll be doing FET every day for brain tumours, and I wouldn't be worrying about FDG that much. It would replace it, but at the moment I have to get hold of F18 from a remote cyclotron, and that basically will come in and basically organised in a week or 2. So when the patient needs to be assessed straight away, we do FDG and try and get some idea, but this sort of situation where you can barely make out any kind of uptake in that area of the actual tumour, you'd want to do that. Now, one thing we are actually going to be getting very soon, at the moment we are doing DAT imaging with TRODAT, and it's kind of variable, our uptake, not in PET, it's in the SPECT clinic, but the uptake we get with that, when it works well, it works beautifully. TRODAT is a tricky agent to label. It is very sticky and doesn't always do what you want it to do. And I'm glad to say that our pharmacy guys are actually getting a new transporter agent for F18. So we'll be basically continuing to offer the TRODAT in the clinic as a free scan, and basically the patients who want to pay for the F18 scan will be able to get that. It's basically a transporter, so it allows us to actually do these sort of imaging, and basically they were talking about this again this morning at the plenary session, and it'd be lovely to tap into that sort of thing. Another thing that's coming up was this. Now, I believe a couple of sites in Melbourne were able to get some of this stuff, Exendin. It's a glucagon-like molecule that allows you to basically look for insulinomas. It's not a common scan, it's not a common condition, but the patients who have it are basically in all kinds of trouble. Basically, they have a tumour which is expressing insulin, and it basically drives their blood sugar down, and they basically wind up in a terrible way. And I've got a number of patients up in Sydney who would benefit from this and man actually just diagnose where the actual tumour is coming from. They've done SPECT with this agent, but this is some of the actual PET imaging you can see. And you've got a very small focus in the actual head of the pancreas and in the tail. And this patient's life will basically be changed radically just by being a surgeon being able to pick out where that is and just remove those 2 tumours. One of the patients I have, she has 2 children, basically 7 and 9. Their 7-year-old died 3 weeks ago, and basically her other son, all basically have the condition, and basically she's passed that on to her children, and she's lost one of her children just recently. So we're trying desperately to get hold of this. There are all kinds of issues getting hold of this trace in Australia, and the people in Melbourne who have got it, I think if they have any left, they basically should hang on to it and just use it, because it's proprietary-wise, they basically become quite difficult to get again. So it's a great agent if you've got that problem, but that's the end of my slides. Thank you for your attention.
We've probably got time for 1 or 2 quick questions. If anyone has a question, please use the microphone so that it can be recorded. No questions? I'd be interested to hear your thoughts on list mode. We've heard a couple of presentations during the course of this that people are talking about respiratory gating and saying, well, it can introduce its own artefacts, so you should use it sparingly. And so is list mode, I think we should be doing everything in list mode. It gives you so much flexibility to then restructure it. Computing power is not the issue now. So is list mode something that can overcome those issues with respiratory gating?
It can. As you say, the main issue has been the actual storage space, but the system's been distributed, like talking to Morris yesterday, he's saying a 2 terabyte hard disk is basically a standard sort of on any machine. And I'm old enough to remember being in Westmead basically having to delete yesterday's SPECT because we had to do another SPECT today, and that was the 2nd SPECT this week. And oh my God, this is terrible. So list mode basically should become like a regular thing. The equipments are actually designed that way now as well.
Are there any other questions? Yep.
Great talk, thank you. How available is FET?
In our clinic, we have a hot cell, and basically our issue is getting hold of the F18. So we can make it any day if we had F18 so in the actual correct form, not FTG, but actual F18. So it basically comes from a cyclotron, but it's like a week or so ordering ahead of time.
All right, we might say thank you. If we've got time at the end, we'll open it up for more questions. Obviously, you've got your little certificate from, you want to say thank you? Now, I'd like to welcome Duncan Vasey to the stage. He's going to give us a presentation on PET MRI in paediatrics.
Thank you, everyone, for inviting me to speak here. That's a picture of our building, which you may have seen on the way in from the airport if you drove down. It's not the newest building on Flemington Road, but we still think it looks pretty good. Oh, click on. Just a disclaimer that RCH has a research collaboration with Siemens Healthineers. We've just recently been announced the paediatric reference site for MMR, so I do need to disclose that. In summary, hopefully I can provide information on these sorts of things by the end of my 20 minutes. To some of you, PET-MR might be a new technology. However, it has been around for about 12 years or so in some form or another, where the first whole-body scanners were developed in 2010. There's currently about 150 installed sites around the world, and 4 of them in Australia, 2 in a clinical setting. I don't know if there are any other sites that are standalone PET-MR without a PET-CT. However, we don't have a PET-CT on site, so all of our clinical work at RCH is on the PET-MR. It's very much based on our clinical service, and hopefully I can demonstrate these points to you. So as I said, it's been implemented at RCH in the last 2 years. It's only just gone past 2 years. We're somewhere between 750 and 800 clinical studies, and the average age of our patient at the time of the scan is just under 11 years. There's a sort of breakdown on what sort of scanning we're doing on it, or what we're performing, with a lot of epilepsy, which you might have seen if you saw Peter Francis's talk yesterday. And our infection imaging is increasing as well. We've only used a handful of radiopharmaceuticals outside of FDG, but that is the majority of our study is oncology, and so there's a lot of work on that. But FET's use is really increasing, and we can sort of have access to FET within a week's notice or so as well. But our clinical service continues to develop our understanding really of PET-MR, and it is always ongoing, whether it's from child to child or whether it's new technologies that are developing. There's some obvious benefits to using PET-MR for versus or over the top of PET-CT in paediatrics, and that's the loss of the CT dose or exposure for kids, which can be anywhere from 2.3 millisieverts for a very low dose limited field to well over 10 millisieverts. And if we are comparing apples to apples, which is a full diagnostic CT to a diagnostic MR that we do, then it's well above that 10 millisieverts. But we do utilise a longer imaging acquisition time per PET bed, so we can administer a lower activity to our kids. So there's sort of standard PET protocols in inverted commas down the bottom that we have, which is 4 minutes per bed, and we increase that to 6 minutes per PET bed for our respiratory gating, which we do perform on the majority of our whole body studies. But there's not really a standard kit or a standard protocol that we have, and we change things on the fly as we're going. And as I said, but probably the main thing to highlight is that we do administer quite low activities of 2 megabecs per kilo, or just on and around, and that's for our epilepsy studies and also for our whole body studies. And the upside of that is we can image, and although they don't show up very well up on there, we can image good quality imaging with as little as probably 11 megabecs, which is our lowest of FDG. And that gives a very small effective dose of around 1 millisievert for an infant, and for an adult-sized patient who are all generally bigger and taller than I am, of about 3 millisieverts, which is quite reassuring to families and also clinicians. We're used to noisy images as well at RCH, because we're always pushing, or our radiologists and nuke med physicians are always pushing the limits of our quality versus diagnosis. So if you think that our images look a little bit noisy as we go, then that'll be the reason for it. But one of the other upsides is that it's a single appointment, and so it's less disruptive to our patients' lives. They often require a PET study as well as other 3D imaging concurrently or simultaneously, as we can provide. And MRI is often preferred for paediatrics due to ALARA principles and CT contrast requirements. And that's currently, the exception is currently in the chest and bone, but I might be able to show you a little bit different as we go. We can perform a diagnostic MR study during our PET acquisition, or during the uptake phase, or following the study as well. So it does depend on what we're imaging and if we want to go back to a select field afterwards. And it's particularly important in oncology and neurology settings, where multiple hospital visits for our patients do inhibit their lifestyles as well. We use sedation or GA more, or increasing over the top of what you would do for PET-CT. But we do try and combine that. So they're not having multiple GA events, because they are having a PET, an MR, and most likely a CT or a bone marrow, or anything else that they would need to do under a GA. We do try and combine that under one single event. And although paediatric anaesthesia is relatively safe, particularly at a dedicated paediatric site, there are risks associated with multiple GA events as well. Back one. So as I said before, it's called, this is a series of pictures that we can have for our chest. We call it our HD chest MR imaging protocol because we're providing high quality MR imaging of the lung as well. It's a 4-minute bed for our whole bodies, but when we look at respiratory gating, which is now with our vendors elastic motion correction, it's not just a single breath monitoring, as you just mentioned with capturing breath. We are monitoring that with our MR sequence too. So we increase our time per bed, and we also acquire a whole magnitude of sequences throughout those motion-corrected beds, which are on the side. So we've got our standard Dixon AC sequences for the attenuation correction, our standard coronal and axial, so we've got 2 planes for our MR, and then we perform 2 extra chest imaging as well. And this is an example of a spiral vibute sequence, which, as I said before, CT is still recognised as being the ultimate looking at lungs, but our MR sequences are getting pretty good, and we always have new ones to sort of use, which is another upshot of having a PET MR with a good MR team as well. And obviously it's been mentioned that PET MR is pretty good in prostate and through the pelvis as well, and it's often preferred for that in peds because of soft tissue. We have increased soft tissue resolution and also in the brain, but it's helpful for delineating normal activity from lymph node activity in the pelvis as well, which you can see here. And although MR doesn't image bone very well, or isn't seen to be imaging bone very well, you can sometimes pick up things that are not necessarily visible in normal CT imaging as well. So we performed a study which was PET and MR positive in the bone, which is obvious. However, a CT that was done at the same time was negative, and it was later proven to be a biopsy-proven metastatic recurrence, but interestingly, they still use the CT to find the biopsy site. So you still need a CT for something. But going on to anything around children and around kids, and care should always be used when justifying any radiation procedure. And although we are administering low doses and we can give a low effective dose to our children, we still ask, is it the right study to use? Is there something else like a CT or just an MRI that can still answer the question for every single study that we get requested? Is there another study that can be easier performed with less resources and within an adequate time frame, but still provide a lower or a low radiation dose? And only once all of these parameters are determined prior to scheduling, we then make decisions as to what needs to be done for that particular kid, whether it's including their assessment of their prior images, what sequences we're going to perform, and any other extraordinary considerations for that child outside of the standard based on their age, their clinical situation, their discomfort or their pain tolerance, and their anxiety, which we do see a lot with our teenagers and our new diagnosis. And if you're going to be laying on a PET MR bed, which you might have seen from an earlier slide of Peter's, that's what it takes to do a whole body study on a patient. This on the left is under a general anaesthetic, and so we've got our anaesthetic equipment there, but all of our hosing and tubing. If you're awake, you're still going to be wrapped up under those coils and into a small bore of 60 centimetres. If you've had an MR before, which is noisy anyway and confining, yet you're going down a smaller bore, and you've just been told at 15 or 16 that you've got cancer, generally you're going to have a freak out, and the majority of the times it's within a 3T magnet. So it is confronting, and we do need to use a whole lot of our paediatric friendly preparations and distractions and well-trained staff. But all of these things that are listed up there, whether it's pain or just psychological issues, do come into play and are really amplified in that setting as well. It's pretty daunting for anyone, and but kids always surprise us, and kids that you think are not going to be able to cope with something can. But before you get to that point, we have to make sure our fasting is correct, and so that's not dissimilar to a PET-CT study. We encourage water throughout it, and we also discourage long or extended fasting times for our FDG studies, I should say. And we aim for an ideal blood glucose of between 3.5 to 7 millimole per litre. We have a baseline, a lower limit for our GA patients because they can't be monitored when they're under GA, and so we don't know if it's too low when they've gone to sleep. The anaesthetists aren't too comfortable with being able to assess them if they've had a hypoglycemic event while they're under anaesthesia. So we do enforce 6 hours of food, and whether that includes waking up their kid before their fasting time so that they are only having 6 hours, that's what we encourage and promote with our patients as well. And otherwise, if it is low and we still need to get the study done, then we might administer IV glucose following a 30-minute uptake time as well. So at least they're getting the benefits of both things. Brown adipose tissue, or brown fat, as it's nicely known as. And muscle uptake is common in peds, and you can try and minimise that as much as you can by keeping patients warm and minimising exercise for muscle and the low-carb, high-protein diet. But also using anxiolytics can prove to minimise brown fat as well. Propranolol has been noted to definitely work, and we know that it does work. However, there are contraindications for propranolol. One of them is respiratory. So a lot of kids have asthma. You shouldn't be giving propranolol to asthmatic patients. So at RCH, we don't give it to our patients that have bronchial asthma and bradycardia or any other cardiac conditions. So we actually have our treating or referring clinicians to prescribe that to our patients because they know their patient better than we do for our one visit, unless they've had it before. When assessing our patients when they arrive, we need to make sure we have a team approach, and that ensures a thorough assessment of our patient's ability to cope. So we might have seen our patient first off and we think they're going to manage, but it means we have an MR tech as well as a nuc med tech involved in seeing our patients, whether that's during cannulating, during their safety questionnaire, to actually assess how the kids are responding and whether they're putting up some red flags for us as to whether we need to look at using anaesthetic, using sedation or giving some anxiolytics at all. We have the nuc med tech performs the preparation, ensuring fasting, medication, treatment, exclusion, etc., and also putting an IV in. And just a small thing, which I'm sure most of you do, but we just keep the stylet from inserting the cannula just to check the blood sugar. It means you're not trying to draw blood out of a cannula that might not, which for kids, putting a tourniquet back on if it's not bleeding can be one of the most traumatic things you can do. So just a small thing. We assess all these things prior to obviously injecting FDG. One of the other things that is important is body habitus, and everyone assumes that kids are small, so they're going to fit into that small bore. But as I said, most teenagers are all taller and wider than I am, and so we have to make sure that they can actually fit in there first. And we have had instances where teenagers didn't actually fit comfortably, which would generate more warmth while they're in the magnet, which means they can't be scanned. So. But to have all that, you need a flexible, holistic approach, and means we can perform studies and uptake and administration and everything, whether it's awake, sedated or under GA, and we need to have consideration for the clinical indication. So the best outcome for a kid is one that gets their study done at the right time and in the least discomfort and the least distress as well. So whether that's a patient being accompanied by their parent or guardian during uptake time, which a lot of people think you shouldn't do, the doses that they're going to be exposed to are going to be quite small, so we make sure that we can accommodate that where possible. And also during uptake time for brains, which Rob will probably tell me that we shouldn't be doing, but whether that's not having a standard set up for FDG uptakes for brains, we do need to have those compromises, but we just make sure we keep thorough notes on what's happened during our uptake times for reporting and for future studies. And we constantly remind our nuc med physicians and our radiologists what we're doing a study for. Are they here for a PET scan, or are they here for beautiful pictures from a PET MR? If they're here for a PET scan to assess their disease, then we need to focus on that first, not trying to do a whole lot of other things with it. So always remember what the study has been asked to assess, and we perform those bits first. And a standard protocol or sequence needs to be changed according to that patient and that setting as well. And that may include, again, Peter stole a lot of my thunder if you saw his presentation, but one of our slides is that we can motion correct for brains as well, off list mode data as been discussed. This is off a bold sequence that Siemens do, and we, with tolerances, same as what was just mentioned, there are tolerances, but when we get to outside of 20 to 30 millimetres, it can prove problematic, but it's either giving a kid a GA or not having a study done or accepting a compromise. So when you're trying to look for very small areas of hypometabolism up here, which you can sort of just see up the top here, we do try and make sure that our studies are using everything that we do have available. And if you're using list mode, as you just mentioned, we can provide our corrected and our uncorrected studies so that we can actually quality assess all of those aspects. As I showed out before, that's a study with a patient on the bed, and we utilise a team approach for our ALARA principles for our staff. So we distribute the work between multiple staff in setup. That process of setting a patient up can take as little as 4 or 5 minutes for a patient that's had a few studies and knows what to expect, to up to 45 minutes for a very sick neonate that requires anaesthetic. So when you've administered some FDG, we try and minimise that dose to our staff as well. But we use multiple staff to position our patient, and including putting those body coils on and any other equipment that's required as well. The majority of patients are around about 7 to 15 minutes to set up though, which hopefully the video will work to demonstrate. Although we normally have multiple staff performing this process, just for the video you can see there's one. So there's a whole lot of comfort devices that we need, and they are all PET AC sponges and coils. The coils are placed over the areas of interest, and for obviously a taller patient, you need to cover from shoulders to toes with the headpiece. But the whole time that we're setting up a patient, we need to be explaining to them what we're doing and giving them plenty of time to react. So that's why you don't rush things and constantly reassure them that everything's fine. It's often at this point when you're putting the headpiece on while they are mummified, we're pointing out the movie in the background and encouraging them to get their wriggles out before they start moving, before they start scanning. We give it a test run all the way through, and it's also at this time when we're assessing whether patients are tolerating it or not. Just as you're putting that headpiece on while we're talking to them and trying to distract them, it's when the teenager's eyes certainly widen up a fair bit, and that's when we're figuring out that we probably should have given them some diazepam at some stage, which does happen. But a little bit about some MR attenuation correction. So our vendor uses and majority do, a Dixon sequence. We're using a Vibe as well at the moment, which is a breath hold. We can perform multiple sequences at the moment to generate multiple attenuation correction maps, but essentially with a Dixon sequence you are requiring an in-phase and an out-of-phase, which can generate a fat and a water, and you end up with a U map or a attenuation correction map. There is commonly the Dixon 4-compartment model. They use an atlas-based bone map off an adult that's incorporated, which doesn't always work for our kids because kids are smaller, but we've got a whole lot of data that we're using to generate our own paediatric bone atlas as well. But also there's sequences that are always being developed, and we're pushing to image bone better as well. So we do have to sometimes accept a 4 compartment model rather than the bone as well. And there are issues that can show. These are from probably our first year of scanning. They're not as current or as common these days with our changes and our MR team's changes to settings. But part of it is our quality assurance to make sure that we don't have an extra bit of skin or scalp or broken bone halfway through, or pelvis that isn't lined up with our patients as well. But that is part of our process before we get our patients off the bed. But the upside of the MR is you can always acquire another sequence and you can reacquire it. It is after the fact, so it isn't simultaneous, but it is you can acquire another one that might be tailored better to that patient. As I mentioned before about comparing apples to apples, if everyone does mention that a PET MR does take longer than a PET CT, but if we did away with not performing our diagnostic MR sequences as well, it still only takes about 20 seconds to acquire that Dixon sequence, and that's our MR attenuation correction. So we can perform a PET MR in the same time as a PET CT with a low quality MR, which is equivalent and probably improved information over a PET CT as well. So there is that to remember too. But you can't perform PET MR, or you can't perform any paediatric study without the required resources, which include and involve distraction, whether that's movies, music or stories, toys. We try to limit our interactive distraction during our epilepsy studies and also during our whole body studies, so they're not using tablets with their hands, but sometimes you do need to accept those compromises to limit sedation or general anaesthetic as well. You need to have the right space, so we utilise CCTV and remote monitoring, particularly outside of inside and outside of the MR room. But majority of things which most people who work with kids will tell you, you need to be flexible, and that includes altering our protocols for each patient on the fly, and that's from patient to patient and also episode to episode. So you need to keep detailed records of what protocol you used and what you actually, what preparation there was, and for future reference as well. But you definitely need access to general anaesthesia for PET MR or medical sedation. So we use clonidine as a last resort in our epilepsy studies, because that does have a limited effect on FDG uptake, but we do use that as well. We inject all of our epilepsy studies awake, and so some of our older aggressive patients do need some sort of sedation, so we use that. But we are increasingly using and having a lot of effect with anxiolytics like diazepam. But pain relief needs to be on hand as well, because it can be a long time when you're in there. A typical study on an adolescent might take upwards of 45 minutes. So if you're laying on a bed for that long, they can get quite painful if they are already in pain. But the main thing is teamwork, so it's essential for an optimum service, and you need to have defined roles and responsibilities for staff radiation dosimetry during their setup, but also for everyone to be a valued member and brings their own strengths to the area. So, as I said, we have a nuke med tech that performs the study with the MR tech. We have our nuke med specialists, physicians and our radiologists, but also anaesthesia staff, nursing staff, play therapists, which I didn't mention a huge amount on, but we use the play therapy and the mock service that we have to assess patients prior to booking them in for a study, and also clerical staff. But it does take a big team, and they're all generally happy, and we enjoy working there, and new challenges all the time, whether it's kid to kid or whether it's from staff to staff. It's enjoyable, and we love working there. So hopefully we do need to thank the RCH Foundation and the Good Friday Appeal, because they provided the funds for our purchase of our PET MR, but particularly the patients and staff. There's a few who are in the room here, but in particular Michael Keane, Peter Francis and Tim Kane. Thank you.
And say thanks for your time, and some really interesting stuff there. I remember I had an MRI recently, and they used to have to get a bit of Vaseline on my sides to get me in, so I'd hate to try to squeeze into one of those little things. Our next presentation is Rob Williams, who's going to talk about it's a no-brainer, why, what, and how to produce quality neurological PET.
So I'm not going to. I'm going to keep this a fairly basic talk and go through some of the basic things that can translate into a clinical practice from a very non-clinical practice. So I haven't got any disclosures of it myself personally. The university's ones are too long to even talk about. And I operate a PET CT facility in a university campus. It's entirely not related to hospital. It's very different to a hospital campus. We do things very differently. We do, for example, we do robotic sheep. We put electrodes into brains to control robots. We scan sea urchins. We look at 20-million-year-old fossils. But we also do other stuff like neurological work, and that's what I'm going to talk about, because a lot of that's going to be translating into the clinical practice. But I'm not going to focus on current clinical practice, not so much FDG. We don't do a lot of FDG. A lot of our stuff now is with the new traces and new research. So I'm going to focus on the trending work. And I'm going to talk about why we need better PET and how to do it a bit better. We're going to talk about the QA that's required, the patient preparation that's required, the scanning and positioning, what you do after scanning, and a few take-home tips. And really what I'm talking about for our bread and butter is the justification for the use of neurological PET in this particular way. And really it's about, in the future, it's really about screening and managing therapies for dementia, not as a diagnostic tool, not with visual interpretation. And a lot of it came about because increasingly therapies are beginning to come about to prevent or delay Alzheimer's disease. And this key paper that was that came out in Nature in 2016, and the extension trials that have followed on from that, and the copy trials that have come on from that, have really shown that we're going to lick this Alzheimer's disease, I think. And in order to do that, we need to do PET really well, because there's been hundreds of trials that have failed before, and the real reason why they failed was that they didn't, one of the main reasons they didn't do PET properly, or they didn't do PET at all. And how to do PET properly to make these trials work is really what I'm going to focus on. So the thing that we need to do in our PET trials for amyloid and tau and so on is to measure very precisely changes over time in the same subjects and across groups. And in this study, they actually gave treatments that removed amyloid from the brain. So the first thing we do is we screen to make sure that there is amyloid in the brain, that we've actually got someone with Alzheimer's disease. And then we want to measure the decline in amyloid with the treatment to see that the treatment they're giving engages the target and how well it gets rid of it. And sometimes we need that, measure that very precisely. If you're giving a drug that stops you accumulating amyloid and you only accumulate amyloid a couple of % per year, and you're doing the scan 18 months apart, you're trying to look for a few % change. A few % change is not going to be measured by visual interpretation. And if it's going to be measured quantitatively, then you need to do very, very precise PET scans. So this is the kind of thing we want to see, because we want to make sure that we can defeat Alzheimer's disease, and the way we do that is with precise measurement using PET. Of course, we need the right therapies, but the right therapies only work with PET as a partner. So we also are going to look at other things, FDG for dementia oncology, that's the more traditional one, and we talked about F18 DAT, VMAT, F18 CIT. A lot of those studies we're doing with tau and so on we're doing, but the more traditional ones we do. Here, for example, is one of the studies we did for the US Army, where we did a Vietnam veterans study, and we applied for and got a Vietnam veterans grant from the US Army, and got cooperation from an Indian drug company, Piramal, and we managed to put together the most comprehensive study that's ever been done on a group of subjects. So we did FDG, we did amyloid, we did tau, we did 7 Tesla MRI, which we've got facilities at the university, we did 3 Tesla MRI, and so we did the whole range of things, really all of them, the tau imaging as well. So we need to quantify all those things, and we need to measure them precisely. And this is where the technologist comes in, because the technologist is about communicating with everyone else. You are in the best position than anyone to communicate with the medical and nursing staff, to communicate with the chemistry people, to make sure the chemistry is done right, make sure the quality control and the timing. Chemists hate being disrupted in time, and they need to know when things are happening. So your communication with a chemist is very important. You need to talk to the physicist, and you need to be a partner with the physics. That means more frequent, more accurate, more precise quality control. And you can do that. You can partner with a physicist to make sure that it happens. And the other person who I think is super, super important is the informatics specialist, the guy who deals with your data and manages to control that data, the informatics, the booking, the detailed timing and recording of the system that you've got. So you can interface with them to make sure that happens. All of these things at a university are all bespoke, and it's easy and it's wonderful. I'm a National Imaging Facility Fellow. We're supplied by the National Imaging Facility, which means we've got a whole lot of resources you might not have at a hospital. But that means the technologists can do some of those roles and take over some of those roles. So some of the QA I do on a daily basis, we need to look at the dose calibrator. It needs to be measured exactly and precisely every day. We need to do barrel phantoms so that we can look at any tiny daily variations in the performance of the camera. We need to do CT attenuation correction checking. We need to do the radiopharmaceutical correction, and we need to do very precise cross-calibration between all those devices. You'll find the barrel phantom is very stable generally in a PET CT, and that's the one you're going to rely on. But as soon as you change anything in your system, whether it's a new barrel phantom or it's changing of any software upgrade on your PET scanner or any hardware changes to your PET scanner, you need to recalibrate everything and make sure it all works. And of course, you've got to do your PET CT alignment. So we do those pretty frequently, and it's important to make sure they're done correctly and precisely. So the technologist, for example, in preparation of the phantom, if you look in the top right-hand side there, the barrel phantoms, you can make sure that you're going to mix that phantom for 6 hours and you're going to get all the bubbles out and all that stuff. The physicists may not have time to do that, but you have time to do that. You can do that well, and that improves your ability to accurately measure the amount of tracer that's inside the brain. So some of the most common problems are pretty basic things, and there are common problems in multi-centre trials. Some of you people are going to be asked to do multi-centre trials. In the last financial year, we did more PET scans in the university scanner for phase 3 multi-centre trials in neurology than any scanner in the world. But increasingly, they want to do trials in multiple sites, not just ours. So that means that you guys need to be able to do them well. And the most common problems are simple things. They're metadata problems. They're getting the timings wrong. They're getting the labelling wrong. They're getting the spelling wrong. And those kind of things really matter. So you need to make sure that you double check everything in terms of all of the details whenever you do a research study as opposed to a clinical study. And when you're doing longitudinal studies, because I think the style of way of doing neuro in research is going to progress and become the way we standardly do it in clinical studies. No longer a visual, oh, this looks nice, that looks nice. That's not going to be the way the clinical world's going to work. It's going to work about precise measurement. So this is really important, right? And this is the bit that people often get wrong. We synchronise our dose calibrator, our PET scanner, our injection time to the second, not even to the minute. The simple reason is that if you do it to the minute, you've got a chance of actually having it appear as though you injected before you actually drop the dose, because it can time over. So you need to set all your timings really to the second, because it really makes it important. Now, at the university, we've set up iPad apps, injection timing devices. We've set up automatic calibration of times to internet time to the scanner, internet time to the dose calibrator. Automatically every day, they're double-checked against an atomic clock, which we've got inside the university, something not every hospital has. But most of you have got one of these, and that can connect to internet time, and you can make sure that your scanner, etc., is set up to the correct time. So my tip is to make it automatic. The time recording is important, and it's important that it's notated correctly. If it says it's going to be 90 minutes, don't write 90 minutes. You actually write the exact time that you actually have done it, because you're going to be doing longitudinal studies. So if you get the timing wrong even by a little bit, it can make a difference. This is flubentabine. This is one of the flubentabine times for the tracers. And if you just get it wrong by 5 minutes in terms of the injection to scanning time, that changes the SUVR of the reference region in the cerebellum by 4%. That's way worse. That has a dramatic effect on the research. You can't afford to do that. You've got to do it to the exact time, particularly in longitudinal studies. Longitudinal studies, right, it's important that you do everything the same. So you've got to do it exactly reproducible. So in the first time, if the timing between the injection and the scan was 90 minutes and 27 seconds, the next time you do it, it's 90 minutes, 18 months later, 90 minutes and 27 seconds. right? So that when you do those comparisons, that's exactly what it comes up with. I know it's tough in a busy hospital with code calls and lunch breaks and everything else to go on, but really think about doing that precision when you do your work. The other thing is to make sure that people stay still. And this is really important. If they move, then that really ruins your scan. And we don't do a lot of FDG scans, but make sure that the sedation's given correctly after it's redistributed. And if you've ever been inside a 7 Tesla MRI scanner, right, it's really claustrophobic. So we have that issue too with the 7 Tesla. And of course, you've got the effects of the magnet which make your head spin. So it really does matter. But you really must help people stay still. I'll talk a little bit more about that. Before the injection, make sure that you put your cannula in early so that any disturbance caused by the pain doesn't change your FDG uptake. It's not so important with the amyloid traces and the tau traces. And noise and light, all of those sort of things. And of course, checking the integrity of your injection. Make sure there's no little leaks, make sure there's no tracer dripping out on a connection. Those kind of measurements are really important so that 100% of that tracer that you've measured, you've injected, has gone in. So you need to double check that. And checking the arm is important as well. And we've got an elaborate iPad app that checks before and after injection. There's many parameters, and it won't let you inject the timing until you've checked all of these parameters in. And those parameters then get directly connected, inserted straight into the scanner without any operator intervention. So there's no transposition of errors. There's no manual paperwork involved. It's all electronic work that happens automatically. So that way you can do it more precisely. And of course, when you do the scan, you've got to make sure that everything's exact. That means all your timings are right, your attenuation correction parameters are right. And we've discovered in our research that the lowest possible radiation required for attenuation correction gives very precise attenuation correction with the CT scanners. So don't be afraid to reduce your dose even in a research setting. And make sure that your scan parameters are detailed and exact for your longitudinal studies in particular and for your projects, your algorithms, your subsets, your smoothing, your voxel size. And of course, the other thing is to make sure that people aren't crossing their legs in the middle of the scan, right? So make sure that they have an empty bladder before you start, and the outer field activity from the bladder is going to degrade your PET scan. Right, particularly with FDG, but there's certainly some bladder uptake in the other traces. And the other thing is coaching. Now, you don't need to be quite as enthusiastic as I've depicted there, but it's important. Use the specialised head holders. We've got a vacuum holder that holds the patient's head in place. But the other thing is to encourage them to stay still. And that means give them the reason why they need to stay still. Tell them how it's going to impact on the research, how they contribute to the research, or how can contribute to their outcome. If you don't tell them, telling a person to stay still is like telling a kid to go and clean their room, right? You need to actually tell them how they're going to get the lolly at the end of it, if they're going to clean their room, and why it's important for them to stay still. And that'll help people stay still. The other thing is to have the proper entertainment. We have full entertainment in our scanner so that they can listen and watch whatever they like, so that helps improve the quality of scan. Some scans we can't do that with stimulation, particularly some of the F-DOPA scans and some of the other studies where we're doing things that might take 3 hours, and that's a bit unfortunate. But if you can entertain them and keep them still, that's always important. If they like AC/DC, well, you're going to have to play them AC/DC. Sorry. The other thing is to look at what we're trying to measure. We do semi-quantitative measurement is the standard for most research studies in terms of that means you're measuring a reference region against the target region. And the reference region is usually the cerebellum or sometimes the pons, but it's at the lower half of the image. And that's going to affect the way you position and do the scan. And it's important to get those sort of details right. Because you need to give some love to that reference region. Now, here's a barrel of F18, and you can see that even though they've scaled up the scan so that we get a similar SUV near the edge of the field of view, at the edge of the field of view, the standard deviation is 3 times as much as that in the middle. That means that there's noise in the image near the edge of the image, even though the standard count's gone. So if you're putting a cerebellum near the edge, then you're making that reference region noisy, and that means your longitudinal data could be off. Right? So it's important to keep everything that you're trying to image, in particular the brain, which you're trying to measure very precisely, most of it in the middle of the field of view, away from those edges. There's two ways to do that. One is to position that way, and the other one is to buy a camera with a bigger crystal. These dedicated brain cameras are not as good as the ones that have the bigger crystal, so think about that. So one way you can get the cerebellum away, I know the standard position is the external auditory meatus, the outer canthus, the orbit. We've all been taught that way back in year one. But the truth is, if you position that way, your cerebellum's going to be sticking right at the edge of the field of view. So what you really can do is just rotate the head. Right? It's a pretty basic thing, but it does make a difference because you're not giving noise into that reference region and you're putting the image right in the middle of the field of view. So the other thing is to look for artefacts. Now, this is an area of intense research we've got at the university. We've got a team of people researching on these researching algorithms. I'm not going to go into that, I can't really at the moment. But at the moment, the point is that some reconstruction algorithms at the moment provide artefacts that may be deferential to these research trials, in particular point spread function. But time of flight's fine. So time of flight you can normally use. It will improve the quality of the image. It's not going to upset any of the quantitation parameters unless it's specifically told in a multi-centre trial that you can't use it. So look at those details and make sure that you do the correct parameter. The point spread function, however, is really not used in any quantitative studies at the moment. Maybe it will. We're in the process of proving whether it can, but we do know that it does produce artefacts. For example, you can see the ring artefact here. So don't use that. And the other thing you've got to think about is how you set up it. So this applies to any kind of imaging, but in particular in the brain where you're trying to quantify stuff, you need to Goldilocks your voxel. That means you need to have the voxel not too small and not too big, right? If you've got two view voxels, i.e. big voxels, then you lose your resolution of your system and you're losing information. If you've got too small, then you're adding noise to the image. And if you try, some of the people are trying to reduce radiation dose, adding noise by having too small a voxel on top of that is really going to create problems. And of course, a lot of the studies we're doing in Alzheimer's disease, we're doing in completely healthy people because that's the only place we can treat them, in which case those completely healthy people, you want to reduce the radiation dose. So you've got to compete against noise. All right, so the other thing is correct attenuation correction, partial volume correction you can do afterwards. Reorientation of images, you need to make sure that outer canthus and the orbit is done for amyloid and FTG, but for tau you want to reconstruct along the temporal lobe, and you need to validate for movement. You need to double check your quality as well. So what you need to do is double check the metadata. We have an automated computer system that compares everything in our books with everything in the scanner that's been extracted out of the scan and double checks the spelling and the typing and the dates and the times and the activities. If you can build a system like that works in your place, then you're going to reduce these number of errors. And the other thing is to have a retrievable, reliable backup system. That means your raw data, not just your DICOM data, so that you can reconstruct it 7 years later exactly the same way. And we record all of that, and we have it mirrored, and we have it backed up in 3 secure locations automatically. And so these are my take-home trips. Avoid human-operated entry devices. A pencil's got a rubber on the end for a reason. Right? So automate everything. So that go paperless, that means great informatics, electronic automatic timing, Goldilocks your voxel, do your daily QA, orientate your head to take care of your cerebellum and keep your patient still. And these are some of the people who've helped us out, and not only with funding but with work. It's important that you work as part of a team, and all of these people really make a difference.
So again, we might, just because we're running right on the time to finish at 12, we might hold questions to the end and maybe after the session is over. So I'd like to thank Rob and hand over his little certificate of appreciation.